Please welcome the Atlantic's Executive Vice President of Marketing, Tyler Watson.
Hi, everybody. Thank you. I'm Tyler Watson. I'm the Executive Vice President of Marketing at The Atlantic, and we're super excited to have everybody here tonight for this important conversation, Redefining Obesity Care, the GLP-1 Revolution. Tonight, we're going to hear from experts who are shaping the future of obesity care. Please silence your cell phones, but keep them handy. If you see or hear anything tonight that excites you, please share them across your social networks. A quick thank you to our sponsor, Amgen, for making tonight possible. And now from Amgen, I would like to welcome to the stage Susan Sweeney.
Great. Thank you. Thank you, Tyler. And yes, I'm Susan Sweeney. And I have what I believe is the best job at Amgen. I have some colleagues in the room who might think differently, but I do believe I have the best job. I head our entire obesity team. And we are so thrilled to be with you here today and to hear the voices of the entire ecosphere that works on obesity. The panelists that we're going to have are fantastic, and I'm really looking forward to it. And although we've made so much progress in obesity care, from the very beginning part of even identifying it as a disease, and also that treatment has really advanced. But even with all of that advancement, there is still so much more to do. Across the world, it's only about 2% of those living with obesity that are treated today. And for even those that are treated, many come off therapy. So we're really looking forward to hearing from the panel. And at Amgen, we're excited about bringing in future treatments in the market and hearing about how we can make an impact for the 98% who have not been able to benefit yet. So with that, let's get the party started. And I'm really looking forward to hearing all the voices in the conversations today.
For a conversation on the defining scale shift in obesity therapeutics, please welcome Pinchas Cohen, Dean of USC's Leonard Davis School of Gerontology, Katherine Saunders, co-founder of FlyteHealth, Orian Shirihai, Professor of Medicine and Molecular and Medical Pharmacology at UCLA's David Geffen School of Medicine, with Thomas Goetz, AtlanticLIVE contributor and host of Drug Story.
Hello, welcome. So I need to tell you all that you are part of a very select audience. There are 5,000 people up the street at the Milken Conference who wanted to be in your seats, and they are not. You are. So consider yourself lucky. Well, this is going to be a fun kickoff to the conversation. As you just heard, obesity, not news to anybody, obesity is a crisis, a public health crisis of growing proportion in the United States and worldwide. 40% of Americans have obesity, and another 30% are overweight. So it's a preponderance of the population. And it has been something that has been going on for decades, rising, and really has been baffling medicine and public health until about 20 years ago when the first GLP-1 came along, and it was discovered that it had this side effect of weight loss. And drug companies being very smart, they honed in on that and took about 15 years, but finally there was an approval for weight loss. And it helped that, I think, the American Medical Association recognized obesity as a disease in 2014. So this first conversation, we're going to talk a little bit about where we are vis-a-vis obesity, GLP-1s, and where we're going. I wanted to start with a question to you, Dr. Saunders. You were one of the first wave of physicians trained in obesity medicine, right after that AMA designation. And so what I wanted to ask you was, like, what is that kind of change that we've had over the last just few years where there has been a viable treatment for weight loss? What has been kind of the impact clinically?
Yeah. So thank you so much for having me here. It's really a pleasure to be with this amazing audience. Taking a step back a little bit, years ago, it was thought that obesity was just a lifestyle problem, that people were just eating too much, exercising too little, and that's what led to obesity. The next step to that would be, treating obesity would just be, eat less, exercise more. We have come such a long way in our understanding of the mechanisms, the pathophysiology of obesity. We now understand that it is a real disease. It's not people's fault. There are so many different contributors to obesity, and obesity is not just a disease in and of itself, but it has so many other health complications associated with, over 200 weight-related health complications that have been identified. So almost every single area of medicine is affected by obesity. We have had treatments for decades, some of which did not turn out as well. And GLP-1s are really, the first treatment that has been just an absolute incredible medical breakthrough in this area of medicine. And so it's incredibly exciting as a clinician. When I started, we had a handful of medications that were somewhat effective, but had more side effects. And now we have, so many more powerful medications. We have so many more in the pipeline. So our ability to, one, really prove to all the, non-believers that obesity is a disease because it can be treated effectively by targeting the dysregulated hormonal pathways, and to help, the millions and millions of people, it's really been absolutely, groundbreaking in the last several years.
Okay, so Dr. Cohen, let me build on that with a question to you. What is going on in the body and society, if you want, that kind of has created this kind of obesity crisis? What is the mechanism behind it, as well as we can understand?
So there's no question that this has been an incredibly rapidly growing problem, not just in the United States. In fact, there are countries that are even worse than the U.S., Central America, the Arabian Peninsula, where the majority of people are obese and diabetic. And I think it's a combination of lifestyle changes, particularly diet and reduced exercise, and maybe processed foods, and possibly other things that contribute to that. And I think that when thinking about obesity as a disease, we used to think that our goal is to reduce numbers, to make the kilograms go down, maybe make the blood sugar go down. But the recognition that obesity is a major cause of both morbidity and mortality is really something that created a lot of attention to try to address that. And I think one incredible thing about the GLP-1 revolution is that it's turning out that GLP-1 reduces mortality. And the mortality curves between placebo and drug is becoming wider and wider. And as we spoke, GLP-1s may be the first true longevity drug because of their reduction of all the diseases associated with obesity, heart disease, stroke, and so on.
So, Dr. Shirihai, let me ask you, because we talked about this a little bit before, and you mentioned that the goal here is not just to, as Dr. Cohen said, to have lower numbers, but to actually be healthier. And so what is that, like your expertise is in metabolism, what is happening metabolically with these?
So first I would like to say thank you for coming here. And I would like to say a word about the revolution. Why we call it revolution? It's not only that it's a revolution that so many people are now being treated, but it is a revolution in our perception that obesity can be treated. And that perception that obesity can be treated has changed the way we act in terms of what we are asking researchers to do, what we are expecting pharma companies to do, what we're expecting insurance company to do. We are now expecting insurance company to cover the treatment. We are now expecting pharma companies to put resources and to put their minds and their power to make the next better obesity treatment. And as you said, GLP-1 is the first, one of the first best treatment, but might not be the best. It was, you can say it was a fluke, right? It was actually a diabetes medication. It ended up being an obesity medication. So now our duty is to find the better one. And then from there, the better and better one. And that goes to your point about our goal is not just to make the patient lighter, but healthier. And sometimes lighter is not healthier. And in order to make sure that the lighter goes with healthier, there has to be a complete package of treatment, healthcare, that is not just here is the injection or here's the pill, go home and do whatever you want to do with it, because if we are not going to take care of the patient in an appropriate way, they might actually damage themselves. Think about GLP-1 like a sports car that you got. If you can do amazing things with it, but you can also do a car accident. So you need somebody to teach the patient how to use it properly, meaning, for example, change their nutrition. If they were just eating snacks all day, they cannot keep eating snacks all day and be on GLP-1, because if they were not getting proper nutrition of vitamins, and now they're going to reduce their food intake, they're going to be in vitamin deficiency. So we need to make sure that they are okay with their nutrition in terms of vitamin. We need to make sure they're not switching just to carbohydrate nutrition and that's all they're eating, because they're going to be in protein deficiency and they're going to lose more muscle. And we need to make sure that we're taking care of their mental health as well, because there is some risks involved there. So we need the entire package. So as I said, there is just 3 layers that we have to think about it, if it's okay to talk about it.
Yeah, well, let me come back to that, because I know those layers and I want to get to them.
Okay.
But what you just mentioned is reminds me of something Dr. Saunders has said, which is that the prescription is not the treatment. And I think that's a really important concept to kind of flush out, because I think the presumption maybe outside of this room is that there's these GLP-1s are somehow a magic switch, and you just take the shot or take the pill now, and you're on your way to weight loss. But that's not actually how it works at all. So let me just ask you to expand on that. Prescription is not the treatment.
Yeah, absolutely. I think, when you take a look at the numbers of, patients who are taking GLP-1s, people stop after several months. I mean, the number of people who are still on GLP-1s after a year is astonishingly way lower than it should be. And those numbers range from, 17% to 50%, but, it's nowhere close to where it needs to be for a chronic disease. Obesity isn't something we're curing yet, although hopefully we'll have a cure at some point in our lifetime. But for now, obesity is a chronic disease that needs long-term treatment. And so just prescribing GLP-1s to every single person who wants a GLP-1, because that's what everyone is, presenting to us clinicians asking for, is really, a setup for failure. And what we need, it's the way I like to talk about this is that the medicine and the science have evolved so much faster than our system to deploy. And, we've proven the efficacy, but now we need to really prove the execution. And we're just not there yet. And it's really bad. Basically, when this kind of care is delivered appropriately, patients, are selected appropriately. Not everyone's a great candidate for a GLP-1. Not everybody needs a GLP-1. And if they are a good candidate and the GLP-1 is decided that, this is what makes the most sense, they need so much education and support to understand, what goes into really good treatment and sustainable treatment. And so I could talk about this for hours, but I will spare you. But this is a topic I feel very passionately about, because there's just such a myopic focus on giving people a GLP-1 prescription, and it's so much more than that. Obesity is so hard to treat, and we need better systems and so many different things to fall into place to really set people up for success.
Well, and I think one of the things that strikes me is how complicated and mysterious the condition is, and then how these drugs work. And Dr. Cohen, your work has explored this kind of the trying to unfold the mystery of peptides and GLP-1s. And I just want to, how well do we understand these drugs and how they work at this point?
Not that well, I have to say. When GLP-1 first came out, we thought about it as a metabolic hormone. I think one of the primary effects of GLP-1 is really as a neuropsychiatric medication that suppresses appetite, as well as craving for alcohol and drugs, which is another really exciting direction for this class of medications. But we don't really understand how it works. We don't really understand why there's so much muscle loss along with fat loss and how to address that. There are other issues that we are concerned about that we don't understand. What happens when you stop taking GLP-1s, which most patients end up doing? There is rapid regaining of the weight, often without gaining back the muscle that was lost. So there's still a lot to understand, a lot to investigate, and a lot of things we need to find new solutions for, particularly the muscle loss, which is, I think, the biggest issue.
Yeah. Okay, this is when I think the layers come back into play. So give us your layers.
Okay. So one way to think about it is that we have to think about three layers that the GLP-1 revolution brought us. One is that we have to start thinking about the obese population as a mix of multiple different type of patients with obesity. GLP-1 does not fit to 100% of people with obesity. There are physicians today in different medical centers have different policies to say there's a counterindication. GLP-1 is not for you. And some examples include what we call sarcopenic obese, or people that have too little muscle for their weight. And if they're going to take GLP-1, it might compromise their ability to function. This especially to the elderly and to those called sarcopenic obese. There is some medical centers that also say postmenopausal women should be a counterindication for GLP-1. So we have to segment the population and give GLP-1 to the right people. Then the second layer is we have to treat them well, which is what we just spoke about, to make sure that there is compliance, that they don't drop off. And the most important, that they don't do the yo-yo. Yo-yo means taking it, stop taking it, and then gaining some fat. Reduce muscle, gain more fat. Reduce muscle, gain more fat. So that's the second layer. And the third layer is what should be the medications for those people that cannot benefit from GLP-1? And what is the future holding for us? And one of the blooming new direction is the compounds or treatments that increase energy expenditure. So instead of reducing the craving for the food, increasing the energy expenditure. So spending the calories, and that would mean that a person can still go and eat, and it actually tend, in the research that is being done today and reported, it tends to spare the problems of lack of vitamin, because the person can still go and get their food that they want. And in some research, showing that it tends to spare the issue of muscle loss. Because people can still go on with normal diets, so they don't have reduced craving. These are the three layers. Think about the third layer as the future, as the opening and finding a new medication, which Amgen is one of those companies that do that.
Okay, well, we'll get to that. But let me, you had a couple salient points. One of them is this idea of just the drop-off, which Dr. Saunders, you mentioned earlier. So it's kind of amazing. 30% of people taking GLP-1s do not finish their course of care, I guess. So more than that. Okay. So how do we actually better manage for that kind of drop off? Like how do you actually, if it's more, especially if it's more than that, if the odds are very high that people are going to drop off, how do you provide care? How do you use the GLP-1s effectively, anticipating that kind of risk?
Yeah, I think, one of the misperceptions is that people stop taking GLP-1s because they're not compliant, or, just reasons sort of blaming patients. And I just want to, reiterate that, obesity is such a complex disease, and sometimes one medication doesn't work for a patient, and maybe that's why they stop the medication. Sometimes they lose insurance coverage. Sometimes the out-of-pocket cost is too high, and so there's so many different reasons why people stop medication. I think that one of the most important things, and I love the idea of your layers, and I have a slightly different take on just from a clinician's perspective of what it's going to take to get us to where we need to be. I think one of the things that I'm the most excited about in terms of the pipeline and what's coming is that because obesity is such a complex heterogeneous disease, there's so many different pathways involved, and for most people, targeting just one pathway is generally not enough. And I have plenty of patients who are non-responders to every single medication out there. And so I think the future of having so many other pathways that we are targeting is just going to enhance our ability to treat such a larger percentage of the population. And then just going back to, what I was talking about before in terms of, how do you keep people on their medication? It's really, selecting appropriate people who, are good candidates for the medication, prescribing in a very personalized way, prescribing with a lot of education about, what it's going to be like to be on this medication, how to change, diet, how to change behavior so that you tolerate it. What do you expect? When you hear all this, side effect hype and people stopping because of side effects, a lot of that can be really mitigated or completely avoided by giving patients education about, how to change the way they're eating, and there's so many different, strategies to prevent side effects, and then, having a strategy for maintenance. Once people reach their weight and health goals, that's not the end of the road. That's really kind of where it begins. And we were talking about, understanding, why people regain weight, when they stop a medication. I think, it's an interesting question to think about, why they wouldn't regain weight when they stop a medication. When we're talking about other chronic diseases like hypertension, hyperlipidemia, diabetes, we classically think of medication as a long-term treatment for a chronic disease. And so when patients stop a medication and regain weight, that's something that unfortunately can be avoided with, all of these strategies that I'm talking about that are necessary to treat this complex disease in a sustainable way and really set people up for success.
Okay, so we've talked about the kind of potential of them. We've talked about kind of the complications of them. I want to see if I could have us leave this group with some sense of what is next and that kind of vanguard of the future. Dr. Cohen, I know you've done a lot of work on this. You've looked at the range of reasons and purposes beyond obesity that people are using these drugs for. So I guess I'm curious to see or to hear what you have to think about it in terms of the next phase that we're going to go into.
So the GLP-1 has been a revolution in health, which is ongoing. It's a $60 billion a year industry. It's going to go up to $100 billion. There's maybe 12 or more different products. There's going to be over 20 very soon. The next big revolution in health is going to be the treatment of sarcopenia. And it's linked, and
which is muscle wasting, yeah.
And it's a major issue with GLP-1s. It's also a major issue on its own with aging. Sarcopenia of aging is the biggest challenge to healthy aging. Frailty as a result of that, falls. That's what gets people at the end. So that's the next big thing in health and in drug development. There are multiple candidates. There's several companies that are developing myostatin inhibitors or myostatin receptor inhibitors. There are other agents that are being developed. I've worked on a drug candidate called MOTC, which is a muscle-sparing weight loss drug that's still in development. And this is where a lot of the energy goes. And this will be developed alongside improving the next generation of GLP-1s.
Okay, so this is where they start to become longevity drugs. Okay.
You know, it is already a life, prevents mortality in people who are taking it.
Right. Please go ahead.
You can also ask the question, who eats the muscle? Where is the muscle going? And there is an interesting answer to that coming from a variety of research. So it's not completely done, but it's actually the brain that eats the muscle. Because our brain needs sugar all the time, nonstop. It needs glucose. And what we do at night at about 3 a.m., we are out of sugar. So the liver, our liver, starts producing sugar from fat and sometimes from a little bit of protein. But if we are inhibiting the ability of the liver to convert our fat to sugar, so it is part of the fat that can actually be remade into sugar and then sent into the blood, and our brain can enjoy it. But it turns out GLP-1 is inhibiting the secretion of another hormone that tells the liver, hey, convert some fat to sugar for me. And it might be that action of GLP-1 telling the liver, hey, don't make sugar, that's exactly when the liver calls the muscle and say, hey, can I have some protein and I'll make sugar out of that? And the muscle say, well, you know, you're the liver, I have to obey. So the muscle sends some protein to the liver to be converted into sugar, and now the brain can enjoy it. And that means that you can add now other hormones that will tell the liver, hey, don't worry, do it. And we might be able to go around that problem just by medicating GLP-1 together with.
So it starts to mitigate some of these concerns. Dr. Saunders, I'm going to leave you with the last word. What excites you about this future?
Yeah, I would say stay tuned for 3 things. One is, other mechanisms and combination mechanisms as, more groundbreaking discoveries. 2, different ways of taking medication, so longer half-lives, oral, just making it as easy for patients as possible since this is a long-term thing. So that's very exciting. And then the third is all of the other indications. Sleep apnea, heart failure, kidney disease, liver disease, the list goes on and on. Alcoholism. There's so much to be, paying attention to and so much to be hopeful for.
Indeed. Well, thank you all 3. That was really enlightening. Thank you for your time.
In the 4th grade, my mother enrolled me into a weight loss program. Throughout high school, I was trying every diet known to man. A cracker diet or rice diet, Atkins, keto, Weight Watchers, Jenny Craig, Slim Fast, OptiFast, starving myself, over-exercising, but it wasn't working. I was always gaining it back. When I got close to 40, a lot of aha moments happened to me. I was at a restaurant with some friends. The chair broke. My main aha moment was the lymphedema. I thought I was going to lose my leg. My physician at the time recommended me to have gastric bypass, and it shrunk my stomach to the size of an egg. But just 2 years ago, I was going through a regain. And my doctor said, you didn't gain that much, but you're getting the comorbidities. You're going to have to do something about this. I asked him, I said, these GLP-1s are out here now. Is that something for me so I can help lose this weight? He said, Kevin, you already did it the easy way before. I was angry, disappointed in him, mad at myself, all kind of emotions were going through. I wouldn't consider that the easy way out because you still have to do the work and maintain your health, eat the right foods, exercise. So it's just not an instant cure. Now I know that obesity is a chronic disease. I didn't know that for the longest time. I just thought it was me. I learned a very important statement. It's not your fault. No one's never, ever, ever told me it wasn't my fault. So when someone tells you it's a quick fix and you're trying to find a way to resolve these issues and to get healthy and to live a normal life, it really, it hurts. I switched doctors. We work together. I see how so many people are going through these hoops. What I went through is really prepared me to help others. A lot of people, they don't know how to advocate for themselves. Sometimes someone else has to be your voice if you don't have the voice for it.
For a conversation produced by our sponsor, Amgen, here to discuss examining the reality of living with obesity. Please welcome obesity patient advocate Kevin Stevens with Ted Kyle, founder of ConscienHealth.
Kevin, thank you so much for that. That is so important for people to hear what real experiences are with obesity. And I wonder if you could just think back to the earliest part of your life and how you came to terms with this condition and how you thought about it.
Ted, I realized that I had an issue with my weight at a very, very young age. My mother took me to a Weight Watchers meeting when I was in the 4th grade. So I'm this 9-year-old child in a room full of adults. Well, I thought I was the only child there. Another classmate was there. So that just made the experience more traumatizing for me. And they're talking about all these adult problems with weight and what have you. And I kind of knew then, I said, wow, this is going to be something I'm going to be dealing with for a while. Obviously, I didn't know that obesity was a chronic disease that can be treated with choices. I didn't know that at 9 years old. So for the next 2 decades, I spent my life dealing with weight bias and being excluded from things, feeling like a failure, feeling like it was my fault. Because at the time, I didn't realize it wasn't my fault. I didn't learn that till later. So when my health issues, I started having a lot of health issues, and I knew that I had to do something. I knew I had to do something, so I turned to, I had surgery, I had gastric bypass.
So tell me a little bit about the changes that you encountered in that middle part of your life with the complications and how you really wound up with that decision and how hard it was.
Well, I developed high blood pressure, I developed sleep apnea, lymphedema, and the thing that really got to me was my A1C was out of control. I was pre-diabetic. And I was worried about my vision with the lymphedema. I thought, like in the video you saw, I was worried about my leg being amputated, things like that. I didn't know. And I was always, why can't I lose this weight? Why can't I lose this weight? So my doctor, he recommended gastric bypass. So I did that in 2011, and it was successful. I lost 220 pounds. And after that, the maintenance for that was just basically every year just get some blood tests, and that's about it. It really wasn't no guidance on how to keep the weight off. But I was successful. Toward the end of that period, toward like the pandemic time, I realized I gained about 45 pounds. And he basically told me, hey, you need to probably do something about this. So I recommended, I brought to him.
And this was the same doctor?
It's my same doctor. I had him for years. And he basically didn't want to hear anything about the GLP-1s. He said, that's for my diabetic patients, you're pre-diabetic. And I said, well, you can give me something that could help me not become diabetic. And he just wasn't, he was against it. And he said, Kevin, bottom line is you just need to eat less and move more. And you already took the easy way out. So I got a new doctor. And long story short, and I found one that he's on a GLP-1 himself. He's diabetic, but he understood me, and he worked with me, and he gave me those options. And I tell people, you have to find a doctor that gives you options. And it wasn't easy. I had some barriers. I had to get approved by my insurance. I'm fortunate that my employer does cover the GLP-1s under my plan, but it's still some hoops I had to go through, some insurance things that I had to go through. And I finally got approved for the drug. And it's been amazing. It hasn't been easy. It hasn't been easy. None of this is ever easy. It almost reminded me of when I first had gastric bypass, and I had to, you have the side effects, but like the previous doctor said, these side effects can be managed, and that is true. And I could see why people stop taking it because of the side effects and things like that. But yeah, I've been successful with that, and now I'm more into the, I'm going into my maintenance phase now.
So tell me about that. Tell me as you look forward, where are you now and where do you see yourself being with what we've all keep saying, this is a chronic condition. This is not something that's one and done, lose the weight. It's not obesity anymore. Tell me how you're thinking about that.
Well, now that I'm in my maintenance phase, I'm working with my doctor. He lowered my dosage. And we're trying to find a safe space where, obviously I don't want to lose any more weight. And that's another thing. I'm more focused now, for the first time in my life, I'm not worried about that number anymore. Right. For years and years and years, I'm 57 years old, I worried about that number. I thought it was so important, but it's not. It's about being healthy, right, and not having those elements. So I'm focused on the maintenance. I'm looking forward to, hopefully, one day there'll be a drug just for maintenance. Right now, we just have to adjust our dosage, but why can't we have a drug just for maintenance? So you have to think about it. And I want something easy and something that's not going to be as rough on my stomach, in my case. And yeah, that's what I'm looking forward to. And I just want people to realize, I'm glad, they can hear the message that, it's not your fault. And obesity is a chronic disease that can be treated if you get the barriers, erase the barriers, and access to care. And just a doctor that gives you choices, a doctor that listens to you.
I think it's so interesting that you say you're not focused on that number, that weight, but on the health. And as you work, and I know that you are an incredible advocate and supporter for other people living with this condition, how do you see people coming along from thinking about this as weight loss instead of health gain?
They have to really realize that you have to, it's your health, because, a lot of people, I feel bad because they hear about the GLP-1s and they think of it as a cosmetic drug. And now we have the treatment bias. I mean, it was always there. Treatment bias, we had that with gastric bypass. But the treatment bias is where you're being judged now that you found something that works, and you're being judged. It's like you can never win. Nothing's good enough. And it's more than just that number, because, you can be you could be heavier and be perfect. For years, I didn't have those elements related to obesity. I was a healthy person, but I was getting close to 420 pounds.
Right.
Yeah.
Right. Mm-hmm. And I hear you saying that looking back on your life, you thought it was something that was wrong with you. And now I hear you telling us that you are in a different place where you know that this is a condition that you want to deal with, but you did not choose it.
Correct. And it took a long time for that. It took a long time for me to realize that it wasn't my fault. I could blame myself, beating myself up for it. And it's difficult, it's hard. And I tried to help other people and explain that to them and say, hey, there is a cure. There's not a cure. There's never a cure. It's a chronic disease, not a cure. But it can be manageable. You can find the right options. And it's a long journey. But it's people just blame themselves, and it's not easy. It's a lot of you have to also think about your mental health as well. It's a big part of it too, because whenever you go into any of these things, gastric bypass, GLP-1s, if you have these issues that you haven't resolved, they're not just going to go away when you lose weight.
Right. Well, I just thank you for telling your story, for supporting other people, because there are so many people who feel completely alone in this.
Yeah, and I don't want them to feel alone. And thank you, Amgen, for inviting me to this event. And I hope that my story, I know you've all seen the videos and what have you, really has an impact on people and on how you develop future treatments for us, for people like me.
Thank you.
Thank you so much.
And now to discuss redefining success after a GLP-1, please welcome health and wellness content creator Amy Kane, Michelle Look, medical director at San Diego Sports Medicine Weight and Wellness, Raoul Manalac, senior director of scientific affairs and external evidence at Roe, with Thomas Goetz, AtlanticLIVE contributor and host of Drug Story.
All right. Well, this is a good follow-up to that last really moving session with Kevin. I think of, I was thinking about like Lipitor's and statins when they came out. There was this whole campaign around know your numbers, and it was this whole mind-blowing idea that you would kind of be tracking progression to a disease. It strikes me that with GLP-1s and obesity, it is in some sense the first like really ultra-digital treatment and kind of paradigm we have for disease. And I think Roe is on the forefront of this. Amy, you're on the forefront of this. So I wanted to just start with that idea of kind of like what is different about this. And I'm going to start with Roe because the timing was really serendipitous. We had COVID, which led to this burst of telehealth, this explosion of virtual care. And then at the same time, the first GLP-1s being approved for weight loss. And right after that, Roe, 2023 started selling or prescribing GLP-1s. What do you, in your experience, Raoul, what was the challenge of that, of like taking a totally digital orientation to this very kind of new paradigm of medication?
Yeah, it was a really remarkable time for all of us at Roe. And before I get into that story, first of all, thank you for convening the panel, and thank you everybody for your contributions here for a very important conversation. And you know, when we started to develop Roe Body, our GLP-1 focused weight management program, the major issue was how do we get the most efficacious mechanism of weight management into the hands of the people who need it most, and ensuring that we took on as many of the complexities for our patient as possible. And we wanted to make sure that there are folks who were treated like Kevin was, who were told that, you know, you just have a failure, a moral failure, that you need to go exercise or you need to go lose weight or you just need to go do something different, that they were not recognizing what was truly happening is that they are suffering from a disease. And what we felt we could do is that we could convene a lot of practitioners who were like-minded, who we could train to prescribe these very efficacious medicines in a very safe manner, develop a technical and technological infrastructure around them so that we could essentially, as our founders like to say, give them superpowers to allow them to see patients not only for the individuals that they are, but also to see the potential that these treatments could give them. And taking the digital and fusing that with the human and making sure that patients, whether they are in New York City, in Los Angeles, or maybe closer to where I'm from in Baton Rouge or in rural areas of the United States, they have the same access to the same high level of obesity medicine care wherever they are in this country, and they can get the most efficacious mechanism of weight management possible. And you know, that's how we really felt that we were meeting the time and the mission with the technology at hand.
Okay, Michelle, now I need to go to you because you have a really fascinating background and kind of approach to this. You're an expert, you're a practicing clinician, an expert in sports medicine and obesity management. So how I imagine there's a lot of data in the kind of care paradigm that you use. How does that work?
You know, actually, it's very similar. Right? Because whether you're an Olympic athlete or whether you're a patient with obesity, they have the same goal. They want to feel better. They want to perform better. And the concept of making small changes in your life with your eating or your physical activity can make a difference whether you're on the podium or you're not on the podium are the same things I do with my patients with obesity. They both want to improve their health, and that's what I help patients do. And now that we have these really great, efficacious tools to help, patients with obesity deserve that level of evidence-based medicine and that level of care. that comes with not only just prescribing the medication, because yes, I agree, access is definitely an issue, and you have done a great job of providing access, but that continuity of care, right? This is a chronic disease, and it deserves chronic management, and that means follow-up, and that means somebody who's going to talk them through the whole process and work on lifestyle. Lifestyle is part of beginning, during, and after weight loss. I just had to mention, because of the panel that was on before us about, well, everybody's going to stop taking the medication, right? We see this high percentage. And as you mentioned with hypertension, what about the percentage of people that stop blood pressure medicines? It's quite high. We need to do better than just only measuring weight, right? We've all said this tonight, but it goes further than just saying our target has always been weight loss. And so when the patient stops losing weight, they think, I don't need the medication anymore. So there's many burdens, I'm sure, that you can, you've experienced this and can give your personal thoughts on this. But I see this in my patients, spending that time after the weight loss, right? When they are at weight plateau, of really explaining that weight loss is not linear, and really get to the point of, why are we targeting this weight? Well, I want to lose 20 pounds more, right? I want 21. Why? Why do you want that?
Well, yeah, 20 is nothing. Let me go to Amy. So if you don't know Amy, she is Instagram and TikTok royalty. Her username is Amy in half, which you can figure out why it's called that. And you really have been part of this digital revolution. And I have to say, you have documented your journey on, I see it on both Instagram and TikTok. I don't know if is it TikTok mostly?
Started on TikTok and now transferred over to Instagram as well. Yeah.
All right. Well, you can tell your story, but I just think, you've showed this honesty and bravery, and there's been, the thing that struck me is there's no apologies to it. Like you are being just well, anyway. So what is it like to kind of show the world what this kind of very challenging process is like?
I mean, I had struggled with my weight since I was a little girl, and it was the thing that I was the most ashamed of in my entire life. And I got to a place where I started to recognize that it wasn't all my fault. I've been on every diet under the sun. I knew how to lose weight, right? I had lost weight many times throughout my life. I could not keep the weight off because I had the disease of obesity, because I have PCOS. And I kept this all to myself. I thought it was my fault. I thought I was wrong. I was bad, led to lots of disordered eating and things of that nature. And once I got on a GLP-1 medication, I was like, it's not my fault. This is not my fault. And this is something that can help me. And then I put in the work. I always say I worked with the medication, right? It wasn't the medication doing all the work for me. I had this thing, my little buddy helping me out. And then I put in the additional work, changing my lifestyle, diet, mental health, all of that. And so then once I lost about 160 pounds, I was like, I got to talk to people about this. I got to let people know how great this is. So I just one day was like, I have a degree in social work. I have my master's in social work. And I was like, I think that side of obesity is not discussed nearly enough. There's lots of people on social media who talk about personal training and dietitian. I would say I feel like I could be a dietitian and personal trainer at this point because I have that wealth of knowledge. But looking at the mental health side of weight struggles and other chronic conditions like PCOS, I just wanted to. I put it all out there, and I receive a lot of feedback from a lot of people because of it. But I don't have shame around my struggles anymore.
Yeah, and I think that what you just said, I know how to lose weight, or I knew how to lose weight. That is incredibly profound, because I think the idea that you can that these drugs help break that cycle is really, I think, one of the things that makes them so exciting. Raoul, you see this, right? I mean, you have a way. Ro has sophisticated algorithms that help manage people through those kinds of, or away from those kind of cycles. Can you give us a peek into the black box and understand kind of what are you managing these for?
Sure. And one of the topics that we've had here today is the discussion about adherence or persistence or patients being able to stay on medicines. And one of the key areas that we find that we have challenges, that our patients experience challenges, is side effects. And side effects are a very common part of the GLP-1 experience. And what we did is that we ensured that we had a great way of our patients being able to reach out to us whenever they needed, 24/7, to report a side effect. And from there, we decided, hey, how are we going to take these side effects and how are we going to operationalize the solutions for these patients in a way that keeps them on medicine for as long as possible and tries to ameliorate as many of these side effects as best as possible. And so we had concentric, essentially, layers of teams that we help our providers, our RN teams, our physicians, our nurse practitioners operate at the very top of their license. And we do so by using very traditional mechanisms, looking, reading messages, or answering messages from our patients, but also leveraging technology, using large language models to help triage patient complaints or patient challenges that they may be having. So again, that our providers can get to the very top of the condition or the situation that they can take care of for that patient. In that way, we're trying to make sure that we get our patients through these rough patches so that they can achieve the weight goals that they have, but most importantly, the health and the life goals that they have as well.
Raoul, would you say that also just creating a welcome space, right? Creating a welcome space that if you stop the medicine and you regain the weight, that call us, it's okay, right? There's not going to be you shouldn't have stopped the medicine. It's expected. This is a chronic disease. And the same we would with blood pressure medicine, right? We don't tell people, you should have never stopped. We just like, hey, this medicine was helping you. Why don't we try it again? Would you agree, Amy?
Yeah, absolutely. I mean, I think, again, that goes to this. There's so much shame associated with obesity for a multitude of reasons. And I think even with doctors, right? So many times I felt ashamed to go to the doctor because for so many times I was given the message, well, you need to lose weight. Okay, I know, but I don't know how. And so I think finding those resources, and I was fortunate enough to find a wonderful endocrinologist that has been supportive of me, has been key to my success.
So, Amy, one question I have is you get a lot of response. Your posts generate a lot of response. Some of it is negative, some of it is positive, some of it are people looking to you for guidance. How do you, just logistically, how do you manage it all? Like it must be a lot to take in.
Yeah, I mean, I always say that the positive outweighs the negative. I get a lot. I mean, if you go into my comment section, it is a wild, often scary place. What I do is I say it has nothing to do with me and everything to do with societies, the messages people have been given around obesity, GLP-1s. I like to say that GLP-1s are literally just the continuation. It's a way to continue shaming people by saying it's cheating, it's the easy way out, it's lazy. I mean, I am called all those things all day long. But the way that I sort of deal with it, so to speak, is I get probably messages. I get hundreds of messages a week saying, thank you for understanding me. I talk a lot about food noise, kind of those thoughts in my head that I thought I was the only one that had these thoughts around food. And so I verbalize a lot of that, and it can be uncomfortable for me. But then people would be like, oh, you have that thought around the birthday cake also at the party? I thought I was the only one that was obsessing about the birthday cake at the party. And so it helps me because I just ignore the naysayers. And I know that it is a much larger reason that they're saying it's cheating, it's lacking discipline, you should just go to the gym. It has nothing to do with me.
Yeah. Well, no, clearly. I mean, I think it's very provocative. I mean, your posts are extremely provocative. They're friendly and cheery, but they're also like you bear all. Like it's pretty amazing.
I think because I was sort of fed up. This has been a lifelong battle for me. It has impacted my life in so many ways. And like I said, whether it was disordered eating or my relationships or just in general, it impacted me in so many ways. And I'm kind of like, this is my truth now. And I put things out there bluntly because I think we should stop kind of skirting around the issue.
Yeah. Okay, Michelle, I have a question. When you're caring for your patients through this process, and especially kind of into the maintenance phase, what rules or what are kind of the touchstones, the heuristics that you use as you are guiding people through? Like what concerns do you kind of anticipate or issues do you expect?
I really don't try to judge people on their goals or what they're, right? They have a goal of a number. I try to get them to, I listen to that. They say, why do you want that weight loss? I want to lose weight. I want to be this number on the scale. And I try to get more into the why. Why is that important to you? How does your weight affect you? And I listen to what they say. And typically, often people will say, I want to feel better, right? I want to function better. I want to live longer. I want to play with my grandkids, right? And the food noise issue does come up often, right? Patients often will tell me when we start them on effective therapy, like they feel free, that so much of their brain was taken trying to get themselves to say no. I shouldn't eat that. I shouldn't do that. I shouldn't want that, right? And then they eat because their brain tells them to, and then they feel shame and guilt about it. And that took up so much of their brain space, and then now they're free to do the things that they wanted to do, which is maybe to be healthier, to eat better, and to be a better wife, to be a better mom. And so that freedom, and so when patients hit that weight plateau, which they will because that is expected, right? That's what I try to go back, and I write it down a little sticky in that epic. And I remember when you first came and talked to me, you said this is what you wanted. You wanted to get off of blood pressure medicine. Look what you're doing. I think we've done a bad job at only targeting weight because we knew more weight loss meant better health outcomes. But now the weight loss, we've solved that issue. We need to think about maintenance, and we need to think about going forward, which is looking at quality of health, quality of life, and measuring it. Things like measuring their cardiometabolic parameters, sure, labs, all those things, but also, hey, I see you. People tell me, I can tie my shoe. I can put my pant leg on by myself without sitting down. Those little milestones, those matter. And when we need to let patients know, those are the things that you came to me for, and those are things that matter. And this is a chronic disease, and we're going to keep seeing each other.
Right. So one of the issues with management is cost and affordability. And I know that Raoul has been kind of on the vanguard here. Both you take insurance and cash pay. I think GLP-1s have opened the door to cash pay more than any other class of medications because there's a very perceptible benefit. How do you feel? I know this is not a clinical question, but it is a practical question in terms of access. So how do you feel about affordability as a issue with kind of continuity of care and management?
I think whenever we were talking earlier about side effects and technology, whenever we ask our patients what are the main reasons why they stop these medications, one is side effects and the other is cost. Yeah. And one of the great innovations that we are very proud of at Raoul is that we want to make sure that you have an access point to the most efficacious mechanism of weight management possible. And if you're an insurance patient, we went out of our way to develop a insurance checker that has been used by over 2 million people in the United States to help them try to find insurance coverage for themselves. And if not, go through a cash pay route, which we're proud to say has evolved into a multi-month experience for patients where combining a multi-month annual plan with the medication at an annual plan will actually be less overall than just the medication itself over the course of a year's treatment. And so we're very proud of the fact that we're trying to innovate on behalf of our patients, take on that complexity for our patients so that they can get on to living their life. And one of those areas too that I would be remiss if I didn't mention it is that food noise is something is a topic that we've discussed here. I can see Kevin smiling here, and where another area of innovation that we're proud of is that we heard this from so many of our patients, from so many of our providers, telling us the story about how the food noise has been quieted. And so we worked with one of our advisors, David Allison, a well-renowned obesity researcher, to develop what we call the RAID-FN, or a food noise inventory that has been externally validated, is currently in use in clinical trials, and we use it every day with our patients. And we use it as a non-scale mechanism of watching how our patients are changing with us and with the medication. And we can see that even after the first dose of the medication, the drop-off in food noise is precipitous. adherence to the point where patients will not even want to move up a dose because they're so comfortable now in their own brain. They're so comfortable in their own existence that they don't necessarily need to see the pounds come off because they've been given the peace that they've been looking for decades for. And so we're really proud of both of these innovations for access for patients.
Okay, one of the questions I had was when we think about management, again, mostly you think about like just taking the medication as prescribed, but there are other things to manage. And Amy, you've covered this. There are a lot of mental health concerns or issues that come up. Like how, both for you and from your audience, what do you hear in terms of like helping people manage some of those other, like identity? You've talked a lot about identity. How do you talk about to your audience about managing some of those other issues that come up?
I think it's so important to acknowledge, first of all, the major impact that it can have when you lose a significant amount of weight, especially so many people I talked to, and what I experienced myself was how different I am treated in society. I've shared things like my children, I feel, are differently treated when I'm out with my kids. People are friendlier, and acknowledging it first, and then being able to talk to people about it. I mean, I'm all about therapy. I love therapy. I mean, whether that could be part of someone's treatment plan. I think having that avenue is key because there is and other things like those non-scale victories, while they can be exciting, they can also be really shameful at times. I mean, I get on every single time I get an airplane. I was on an airplane this morning, and I still think to myself, oh, my seatbelt fits easily now. And that was something I worried about in the past. And that's something so many people worry about. So I think to answer your question, also just relating to others on it is huge for someone else to be able to say, oh yeah, I experienced where it was hard for me to, zip up my boot, right? Or whatever else it might be. I think that really reduces the shame, which in turn, from my experience, how do we break the shame cycle is to be open and vulnerable about it.
Okay. All right. Well, last question. And if we can be a little quick to go just down the row. What do you think the future holds? There are all these different kind of formulations, new drugs on the horizon. From your perspective, from your orientation, what do you think the future holds for obesity treatment and management, I should say?
Sure. Well, obviously not as a clinician side, but I think that as much as we talk about, there's still so much shaming and judgment around it. There is, people are coming around, and there is becoming more understanding that obesity is a disease. And also, I mean, for me personally, like I said, I have PCOS. I've seen so many people talk to me about other forms of how these medications are helping, whether it's addiction, or people talk about their anxiety being reduced, OCD. I mean, I don't know the clinical side of it, but just so many other things that I think are going to come up from this. But yeah, I think that even though there's still a lot of naysayers, I do see a positive light at the end of the tunnel.
Good. Dr. Look?
Okay, I'll keep it brief. I know that you address these with all the other indications that GLP's done, and we talked a lot about food noise, but let's not forget inflammation and what inflammation is going to do to the body. And I know a lot of the new compounds that were coming down the market, specifically addressing the lean mass loss. And I just want to mention, as a sports medicine, I think there's a lot of fear mongering about the amount of lean muscle mass loss. And let's remember that it's very reassuring that these GLP-1s are reassuringly losing more fat than muscle. And it's similar to what we do with any low-calorie diet, keto, intermittent fasting, anything, or bariatric surgery. We lose, on average, 3 pounds of fat for every 1 pound of lean mass. And so relatively, while we're losing lean mass, your percent lean mass with the body actually increases. And this is just measurements, people. This is just lean mass on a body composition or a CT scan. This is not function. We see this every day that our patients are functioning better. So muscle quality is better, and the amount of muscle that they have is better. So let's a little bit, while yes, we're coming out with medications that will hopefully address this decrease in lean mass, it's not something that we're very concerned about, that we're creating a whole population of frail people, because we're not.
Okay, Raoul, last word.
Yes, the first question that patients answer whenever they come to Ro is, what are the things you want to accomplish with Ro? And what I am most excited about is being able to help so many patients, millions at a time, come to Ro and help find their path to achieving those things that they say that they want to accomplish, and being able to work with a great technical team, a great digital team, to scale the expertise of doctors like Dr. Look, so that we can make sure that patients like Kevin, like Amy, are no longer ever marginalized, and that the back corners of our country aren't left disenfranchised from this wonderful treatment for their metabolic and overall health. That is what excites me the most, is to be able to bring that to anybody who needs it within this country.
Great. Well, thank you all. That was very inspiring. Thank you.
Please welcome back to the stage the Atlantic's Executive Vice President of Marketing, Tyler Watson.
Just here to say a quick thank you to all of our speakers who led us in some amazing conversations tonight. Thank you again to Amgen for making tonight possible, and thanks to all of you for spending your evening with us. Thank you. Have a great night.